can start.
Yes. So this is a case of acute rheumatic fever. To start with the demographic details, a 17-year-old Muslim female patient XYZ belonging to lower socio-economic class residing at Morbi, Gujarat, came to Civil Hospital Rajkot with chief complaint of difficulty in breathing for 3 months, cough for 2 months, fever with chills for 1.5 months, multiple joint pain with rash for 1 month.
Okay, just a minute, Jaimin. Can you tell me what is the importance of age in cardiovascular patients?
Yeah, so different types of diseases occur at different age. So in the first decade, we'll have congenital diseases mostly, with predominant left to right shunts. And on the second decade, rheumatic heart disease chances increase. And
rheumatic
even
heart disease. And what about rheumatic fever?
Yeah, even in the commonest age group for rheumatic fever is 5 to 15. So there is an overlap between first and second decade of life.
Right.
And
anything else?
Then for second decade,
for second decade. And which cardiovascular diseases are common in older age?
Ischemic heart diseases, mostly atherosclerotic related diseases.
Right.
Yeah. And even thromboembolic disease.
Okay. And as you mentioned, rheumatic fever. Can you tell me which manifestation of rheumatic fever has female predominance? Like it is so much in females that it is almost never seen in post-pubertal males. Can you tell me which manifestation of rheumatic fever?
Is it joint pain that occurs mostly in females?
Oh, it's syndrome's chorea.
Yes, Sydenham chorea, yes, in more in females.
Now tell me, what is the importance of, as you have mentioned, lower socioeconomic class? What is the importance of socioeconomic class in cardiovascular patients?
Most of the time, especially in this case where the disease is infectious, improper diagnosis because of less exposure to healthcare, and then even if they have diseases, they don't go for treatment or they leave the treatment incomplete. So and with most of cardiovascular diseases, you see that continuous treatment is required. So cessation of treatment.
Okay, as you have mentioned, rheumatic fever, is it more common in lower socioeconomic class or upper socioeconomic class?
It is more common in lower socioeconomic class and in the developing world.
And why is it so?
Because of close quarter exposure and living in urban districts and
because of overcrowding and unhygienic conditions, right?
Yes.
It's always seen in lower socioeconomic class.
Yes.
Now you have mentioned about difficulty in breathing. So what terminology do we use for it, Jaimin?
Yes, dyspnea we call it.
Okay, so what is the definition of dyspnea?
There is difficulty in breathing, and breathing is actually, there is increased work of breathing. It is training for the patient.
Right. So I might be climbing stairs and after that I may become breathless. So is it dyspnea?
It is dyspnea, but it is not always pathological.
So what is dyspnea? The definition of dyspnea is abnormal, uncomfortable awareness of breathing. Right now I'm breathing. I cannot even realize it that I'm breathing, right? So, but when I realize it, that abnormal, uncomfortable awareness of breathing is called dyspnea. Can you tell me some causes of dyspnea, Jaimin?
Yes. First, one of the commonest causes is sedentary lifestyle, and there is deconditioning of lung muscles and heart. So that can cause dyspnea. Then if there is chest tightness along with dyspnea, it could be asthma or CHF. And then gasping dyspnea. Yeah, then gasping causes could be COPD or pulmonary embolism, or even fibrosis or pneumoconiosis can cause dyspnea.
Yes.
Then there will be pneumothorax, tension or hemothorax. Then certain.
What are the cardiovascular causes of dyspnea?
Left heart failure is a common cause.
Right.
Then pericardial diseases such as constrictive pericarditis or even acute pericarditis. Then certain vasculitis are very common, especially in this group, which is young female. So polyarteritis nodosa or even Wegener's, Churg-Strauss, lupus could be.
More common ones. Do you know any neurological cause of dyspnea, Jaimin? Neurological cause of dyspnea?
Yes, certain cases where there is decreased activity of diaphragm, such as Guillain-Barré syndrome or myasthenia gravis or even Lambert-Eaton syndrome initially.
Right. And other any miscellaneous cause, non-respiratory, non-cardiovascular, non-neurological?
Yes, anemia can be.
Very good, very good.
Yeah.
Anemia, right?
Yes,
and
yes.
also diabetic ketoacidosis, there can be dyspnea, right?
Yes,
So,
yes.
do you know any scales of grading dyspnea? The classic system or the grading, can you name few?
Not aware of the grading actually.
Do you know about NYHA classification?
Yes, that is for cardiac causes
Okay,
of
so
dyspnea.
can you tell me what it is?
Yes, NYHA, there are 4 classes where it is based on the effect of activity on dyspnea.
Right.
So at stage 1, it will be after severe activity, then the same activity with less rigorous and earlier onset of dyspnea is NYHA class 2. Then even if it occurs in daily activities, then it is NYHA class 3. And if it occurs at rest, it is NYHA class 4.
Yeah, that's right. But as you told, it is applicable only for cardiac patients. So for non-cardiac patients, do you know of any scale?
I'm not aware actually.
Okay, it's MMRC. One is MMRC scaling and the other one is Sherwood-Jones classification, right? Okay. Second complaint you have mentioned about cough. What are the cardiovascular causes of cough, Jaimin?
Cardiovascular causes could be, first is left heart failure because of increased fluid retention. Right. Then it could be infectious. Then even drug induced it can be, if you are talking about cardiovascular, such as
which drug will cause cough?
ACE inhibitors.
Yeah,
very common.
Okay, good.
Then,
which ACE inhibitor causes least cough? Are you aware of that?
Is it captopril?
No, it causes maximum. The least is caused by perindopril. Okay.
Perindopril. Okay.
Perindopril. Okay. In mitral stenosis also you can find cough. Okay?
Yes, mitral stenosis, regurgitation, both can occur. Right? Yeah.
Then in failure, pulmonary edema. And do you know any cardiovascular cause of hemoptysis?
Cardiovascular cause of hemoptysis. Yes.
In this also you can say mitral stenosis, right?
Yeah. Then so any case where there is left heart overload, it can transmit to lungs and cause hemoptysis.
Also pulmonary thromboembolism, it can cause hemoptysis.
Yes.
When will you call hemoptysis as massive hemoptysis, Jaimin? When? What is the criteria of calling a hemoptysis as massive hemoptysis?
If there is greater than 600 mLs in 1 hour?
No, in 24 hours.
In 24 hours, 1 day, yes.
And in one episode, if there is one episode, then what is the criteria?
Is it 150 mLs or?
Yes, right. Next you have mentioned fever with chills. Can you tell me some cardiovascular causes of fever?
Cardiovascular causes of fever, if it is infectious, then one is acute rheumatic fever, which is very common.
Right. Have you heard about infective endocarditis? Yes,
infective endocarditis and most valvulitis, it causes fever, most of the case of valvulitis. Then with myxoma also in older age group, it can cause fever.
And what are you have mentioned about rheumatic fever? What are the features of rheumatic fever? What are the clinical features of rheumatic fever, Jaimin?
For one of the commonest manifestations is migratory polyarthritis, which is then carditis. It can be pericarditis, myocarditis, endocarditis.
Yes.
Then subcutaneous nodules. It is very common. Then erythema marginatum, which is a commonest rash in this. And then sydenham chorea, which we discussed is common in females.
Next, you have mentioned about multiple joint pain with rash. What is the nature of arthritis in acute rheumatic fever? What are the features of joint pain or arthritis of rheumatic fever?
The arthritis is mostly migratory. It starts with large joints and mostly involves large joints. It is dull, aching in pain, and it can be quite debilitating. Mostly large joints, as I said, wrist, ankles, knees are involved. It is often unilateral.
Most common joint, Jaimin, to be affected. Most common joint to be affected.
It is knee.
Right.
And it is often unilateral.
Rather than using unilateral, you can say asymmetrical. Asymmetrical.
Yes, asymmetrical.
Right?
Yes.
Anything else you would like to say about arthritis? What is the difference between arthritis of rheumatic fever and arthritis and rheumatoid arthritis?
Rheumatoid arthritis is symmetric and it occurs in smaller joints of fingers.
Right. And rheumatoid arthritis leaves residual deformity. Is there any residual deformity in rheumatic fever arthritis?
No, because it is migratory, it will not leave any residual effects.
Right. But if in rare cases it is present, then what it is called?
I'm not aware of the term, but I have.
It is Jacquard's arthritis. Okay.
Jacquard's arthritis.
Right. Now you can move ahead, Jaimin. Next slide.
This is about the chief complaints. It is fever with chills and rigor, throat ache, hemoptysis, joint and body ache, shortness of breath, leg swelling with rash.
Wait 1 minute. Here you have added 1 point, throat ache. So what is the significance of mentioning this? How is it so important and vital to our case?
Because this age group is consistent with rheumatic fever. Throat ache can be the inciting event of a cardiovascular problem in this case.
Right. And what is the causative organism of acute rheumatic fever, Jaimin?
Group A strep, such as pyogenesis.
Right. Yes. And what is the pathogenesis behind this? Like why it happens?
Yeah, though initially it was thought, in fact, this is still the prevalent idea that there is molecular mimicry with M protein. So as the antibodies are formed against M protein, there is molecular mimicry with cardiac proteins. So,
only M protein? Only against M protein?
No, against also the factors which interact with M protein, such as laminin, fibrogenin, and the subepithelial contents.
Also N-acetyl glucosamine.
Yes,
right?
N-acetyl glucosamine. Yes, that is a part of the capsule of the group S strep.
Right. Shortness of breath. Okay. You have mentioned about leg swelling, I see. So what it is called? It is called edema, right?
Edema,
so what is the definition of edema, Jaimin?
Any swelling due to fluid accumulation beneath the skin or in the and it is caused by extravasation of fluid from veins. It is edema.
Exactly, accumulation of fluid where? In which compartment of fluid?
In which compartment of fluid?
It's the interstitial space. Okay,
interstitial space.
Interstitial space. Can you tell me some drugs which can cause edema?
Yes, there are actually a lot of drugs. First is vasodilators can cause edema, such as the calcium channel inhibitors, direct vasodilators such as minoxidil, nitroprusidine, etc., hydralazine. Then even alpha-2 methyl dopa can cause edema.
Very
so
good,
one class is the vasodilators.
Also, NSAIDs very commonly causes. Cyclosporine can cause it.
Yes, cyclosporine, NSAIDs, and even immunotherapy such as imatinib and so cyclosporine is included in that. Yes.
Right, Jaimin. So move forward.
Okay. So this is history of presenting illness. Patient was relatively asymptomatic before 3 months when she developed complaint of difficulty in breathing, which was insidious in onset, gradually progressive. Initially, patient used to get breathless only on exertion, but now it has progressed to such a state that she is breathless at rest. Before 2 months, patient developed cough with expectoration containing blood in sputum, non-foul smelling. Patient also complains of bilateral leg swelling, insidious in onset and gradually progressive.
Pause for 2 minutes. What is platypnea, Jaimin? What is platypnea?
Yes, platypnea is a form of dyspnea which gets relieved in supine position.
Right. So means patient is breathless at which position?
She's breathless.
In platypnea, breathlessness is in which position?
It is in the standing position.
Yeah, upright posture. Okay. So
yes, upright posture. 2
causes of platypnea that you know of?
First is, I remember, is myxoma, and second is hepatopulmonary syndrome. If
very good. Right. So how will you differentiate between cardiac breathlessness and respiratory breathlessness, Jaimin?
Respiratory breathlessness is from the cardiac
breathlessness is more associated with exertion.
Cardiac breathlessness is associated more with exertion.
Right. And which is associated more with chest pain?
Cardiac causes. Yes.
Right? Respiratory will be more associated with cough and it has poor correlation with exertion, right?
Yes.
Right. And when you do cardiopulmonary exercise testing, if heart rate increases more than 85% of what is predicted, it is more likely to be
cardiac. Yes.
Yes.
Or if the
And
blood pressure increases or if it drops or there are ECG changes, it is also cardiac.
Right. Can you tell me what is the difference between PND and orthopnea, Jaimin?
PND is actually an early stage where after going to sleep, after 2 or 3 hours, there is breathlessness and the patient wakes up. And he often tends to sit in a one place or walk around to resolve that dyspnea.
Right.
And it does not occur another time in night. Whereas orthopnea is any time you lie down because of fluid redistribution, it will cause dyspnea.
Why is it so? Why it occurs only at night? PND, why it occurs only at night?
Because you need, and because it is less severe, you need sympathetic drive to cause that dyspnea. And sympathetic drive is obtained from REM sleep, which is around 2 to 3 hours after you fall asleep.
And what is the mechanism behind orthopnea?
Orthopnea, because when you lie down, there is fluid distribution. So from legs, and so the venous return is increased. So there is fluid distribution.
Circulation, right?
Yes.
Right. So what we see that PND, it occurs 1 to 3 hours after going to sleep. Orthopnea will occur
anytime you go supine.
Within 30 minutes, right? And mechanism of both is different. PND is caused because of sympathetic drive during REM sleep, and orthopnea is caused because of the redistribution of blood flow.
Of fluid,
Right. And PND indicates which side failure, left or right?
Left.
Yes. And orthopnea?
Orthopnea, it could be either with left or right.
Right. It can be either, right?
Yes.
Okay. Then, okay. And now tell me, Jaimin, what are the signs of dyspnea? Like many times patients do not complain that they are breathless, but we can examine and we can say this patient is breathless. What are the signs of breathlessness?
The patient can be gasping, or it will say it has tightness in chest. Then even use of accessory muscles could indicate dyspnea.
Use of accessory muscles. Can you name some accessory muscles of respiration?
Yes, the recti and the obliques from the abdomen, then the serratus anterior and posterior.
Right.
Then even the sternocleidomastoids can help lift the lung apex.
Right. Okay. Then I can see you have written about cough. Right. Okay, go ahead, Chef.
Continuing on the history, then she developed high-grade fever with chills not relieved by medication, continuous in nature. Patient also complains of multiple joint pain for past 1 month, which was insidious in onset and progressed to such a state that girl had difficulty in walking, more frequently involving knees, which is migratory and asymmetric in nature, relieved by medication. Patient also complains of non-itchy rash on bilateral upper limb, which is pink in color and transient in nature. The rash worsens on taking hot showers.
Okay, Jaimin. As you have mentioned about rash, tell me if you're considering it as acute rheumatic fever, this rash will never involve what part of body?
Never involve the face.
Very good. It will never involve the face. And what is the most important thing about this rash?
Sometimes when we are examining, it comes and goes.
Yes, it's just transient, and also transient. It's the most specific feature of acute rheumatic fever. It is rare, but once it is present, it is one of the most specific features of acute rheumatic fever, right? How will you manage this arthritis? Can you tell me?
NSAIDs are pretty effective.
Arthritis? Okay. What is the dose?
NSAIDs can be pretty effective. Dose I'm not aware of.
Okay, it's pretty high dose. Tablet aspirin, if you give, then you have to give 80 to 100 mg per kg. So just imagine if you are having a 40 kg child and you are giving 100 milligram per kg. So it will become like 4 grams. So
yes, which is very high.
It's a very high dose of aspirin. Other alternate that we have is you can use tablet naproxen.
Yes.
Right? Go ahead, Jen.
There is no complaint of abnormal awareness of heartbeat, no complaint of chest pain. There is no complaint of decrease in urine output. There is no complaint of loss of consciousness or lightheadedness. There is no complaint of involuntary movements, no complaint of backache, headache, or hematuria. Just
pause. You are mentioning no complaint of abnormal awareness of heartbeat. What it is?
It is, I am mentioning palpitations.
Palpitations, right. Yes. So can you tell me one cause of positional palpitation?
Positional palpitation.
It is also myxoma, right? Atrial
Yes,
myxoma can cause
yes.
positional palpitation.
Positional palpitations, yes.
Now, which is the most common structural heart disease which presents as palpitation?
Mitral stenosis,
No, most common structural heart disease.
structural heart disease.
It can occur in MS, but it is not the most common. Most common is MBP, right? Mitral valve prolapse.
Yes.
Next, I mentioned about chest pain. So, what are the cardiovascular causes of chest pain, Jaimin?
It could be, most common is ischemic, which is
Right.
mostly in elder groups.
Right.
Then pericarditis can present as chest pain.
Okay. Pericarditis, how will you differentiate between the chest pain of ischemic and pericarditis?
We can do an ECG and pericarditis will show ST elevations in all the leads.
I'm asking just about the feature of chest pain.
Okay. Pericarditis will be pleuritic in nature, and when the patient leans forward, it will decrease the chest pain.
Right, right.
Yeah. And pulmonary embolism can occur, can cause chest pain. Yes.
Which valvular, can you name some valvular heart disease which presents with chest pain?
Yes, aortic stenosis is common. Then aortic regurg can also cause chest pain.
Yes, it causes nocturnal angina, right?
Yes, yes.
Next. It's very commonly seen in MBP also, right? MBP you have to mention. And also if MS patient develops atrial fibrillation.
Yes, then chest pain will occur. Right? Yeah. Yeah.
Oh, okay. Next, you have mentioned about no complaint of loss of consciousness or lightheadedness. Can you tell me some cardiovascular causes of syncope or lightheadedness?
Atrial myxoma can cause lightheadedness, positional.
Yes,
then aortic stenosis and regurgitations, more commonly stenosis.
More commonly stenosis, right?
Yes. Then even mitral valve disease, when there is decreased cardiac output, it can cause.
Okay. Have you heard about Stokes-Adams syndrome?
Yes, Stokes-Adams syndrome.
What is it?
It is when there are the person feels lightheadedness and it recovers after some time, which is a form of there is AV dissociation and PR interval increases.
Right,
yeah.
Right.
Yes.
Next, you have mentioned about no complaint of involuntary movements. So, what involuntary movement were you expecting in this rheumatic fever patient?
Sydenham chorea was expected because it is a female with suspected acute rheumatic fever.
What are the cardinal features of Sydenham's chorea?
The tongue chorea is very common.
Right. What it is called?
I forgot the term actually.
It is Jack-in-box phenomenon, right?
Yes, Jack-in-box phenomenon.
And any other? Do you know about dinner? It also causes dinner fork deformity, right?
Yes.
It also causes milkmaid's grip, right? It's called milkmaid's grip. It shows dinner fork deformity and Jack-in-box phenomenon. Now, can you tell me when this Sydenham's chorea gets relieved? During which activity? During sleep, it disappears, right?
Yes.
How will you manage Sydenham's chorea?
Initially, haloperidol was used, but nowadays, atypical antipsychotics can help relieve Sydenham chorea.
No, we use carbamazepine or sodium valproate, right?
Yes, yes. The recent over haloperidol, this is preferred nowadays. Yes.
So, why do you think that in your patients, Sydenham's chorea is not present? Like, why? You are having arthritis, you are having fever. Is it present in all the patients? Sydenham's chorea?
No, it is not. Not present in all the patients, and it also onset is a little later.
Right. So, can you tell me which two manifestations of rheumatic fever never occur together?
Is it arthritis and Sydenham chorea?
Very good, because arthritis is one of the earliest features.
Earliest, yes.
Chorea comes late, so they never occur together. And which two conditions occur together? Like if it is present, then we can definitely say that the patient is having active carditis. Which manifestation of acute rheumatic fever?
Which two should be present, right?
Like
so arthritis and valvular.
It's active carditis. It is subcutaneous nodules. Okay.
Yes.
If subcutaneous nodules are present, Jaimin, it always indicates active carditis. Where do you look for subcutaneous nodules?
They are around joints and on the hands and feet. You can find subcutaneous nodules.
Exactly. Can you tell me which joint it is more commonly to be seen and where?
Yes, around knee.
It is more common in occiput and elbow, right?
Okay.
Right. And then last line that you have written is no complaint of backache, headache, and hematuria. This, what do you want to rule out by asking this particular line?
So for hematuria, I am trying to rule out other complications of strep infections.
Okay.
With
this three complaints that you have mentioned are very classically seen in which cardiovascular disease? That backache, headache, and hematuria. Generally, it is very commonly seen in infective endocarditis, right? In fact, in infective endocarditis, one of the first clinical features is backache because of discitis. Also, due to some embolus, there can be headache, and also because of thrombi in renal, it can cause hematuria, right? So, by this particular line, in a way, you have ruled out, or you can say you have taken a diagnosis more towards rheumatic fever rather than infective endocarditis.
Endocarditis,
right?
Yes.
Right. Now, move ahead, Jaimin.
This is the past history. No history of hypertension reported. No history of diabetes mellitus type 1 and 2 present. No history of coronary artery disease. No history of cerebral vascular accidents. No history of tuberculosis. No history of jaundice recalled. Patient has similar history of high-grade fever with disabling joint pains in preschool age, which was relieved by large doses of some unknown medication.
This is very important history because you have elicited here that in preschool age, patient had got some disease, has got some fever with disabling joint pain, which was relieved by large doses because parent had to give very high, so they remember, right?
Yes.
So tell me how will, in this way you have elicited. If I want to elicit a history where the patient is taking tablet warfarin, how will you elicit that history? I want to elicit a history, but patient is uneducated. They are not having any documents with them. But I want to elicit the history that they are taking tablet warfarin. How will I elicit that history?
You can ask about the color and the color of tablets. You can ask, and you can ask about the time at which it is taken and after which event it was prescribed.
The color is not a very right answer about that because color it's not having a very specific color. But second thing you told, timing. It is very particular in case of warfarin. So what its timing? Can you tell me the time at which warfarin has to be taken and what advice do we give to patient that when he's taking warfarin?
I'm not aware of the time at which it is taken.
Warfarin is generally taken at 6 p.m. in evening. And since, as you know, that warfarin is having multiple food and drug interactions, we always advise patient to not eat or take any other medication 2 hours before and 2 hours after taking warfarin. So you can ask patient in local language that do you take any medicine at 6 p.m. in evening and without any other food item or other associated medicine, right? Similarly, how will you elicit the history of digoxin?
We can ask about their vision if there have been episodes of yellow vision, and
it is digoxin
that is also
toxicity. Jaimin,
yes, that is toxicity.
I simply want to ask patient that you are taking tablet digoxin or not, but he is not having documents, he is not educated. By what feature will I elicit the history of digoxin? How many days in a week digoxin has to be taken? Do you give it all 7
no,
days?
Not all 7 days, but
as you mentioned, it's a very toxic drug, right?
Yes.
So we only give it 5 days a week. We do not give it on Saturday and Sunday. So we can ask patient that is there any medicine which you don't take on Saturday and Sunday, but you take on rest of the days, right? So in this way, you can elicit the history of digoxin. In warfarin, you can also ask, because we have to monitor INR of the patient. You can also ask that do you get tested for INR at regular intervals? So when you will ask such questions, it will be helpful to know whether the patient is taking that drug or not, right? Okay, Jaimin, I want you to move forward.
Family history was insignificant.
Okay. So, does genetics have any role to play in acute rheumatic fever? Is there any genetic predisposition to acute rheumatic fever?
Not that I am aware of.
Okay, there are HLA DR4.
Yes, HLA mutations. Yes,
Yes.
it is of the recent research that HLA subset 2 type of mutations are there.
4 and 7, right? They are more commonly,
Yes.
they are genetic predisposition to acute rheumatic fever, Jaimin, right?
Yeah.
Move ahead.
Yeah. Personal history, patient has mixed diet with unaltered sleep, bowel and bladder function with no known addictions.
Okay. What is the importance of diet in cardiovascular patients, Jaimin?
If the diet is, especially in older groups, if the diet is high in cholesterol and fats, it can increase the prediction of ischemic heart diseases.
Okay. Anything else? Anything you know about micronutrient deficiency which can cause heart failure? Which micronutrient deficiency can cause heart failure?
Selenium.
Very good. Selenium
and
thiamine, right?
Yeah. Yes. Berry can. Yes. Wet berry has heart failure.
You have mentioned about sleep. What is the importance of asking about sleep in cardiovascular patients?
If there is PND or positional change or positional dyspnea, the sleep will be altered or interrupted, and the patient is very aware of it most of the time. And then and even with sleep apnea, the patient or the patient's relative will complain.
Very good. Yes. Right. OSA is itself in a risk factor for heart failure.
Yes,
right?
Because
and also orthopnea and PND complaints disturb his sleep.
Yes.
Okay. Go ahead, Jaimin.
Summary and provisional diagnosis. 17-year-old female with complaint of exertional dyspnea, hemoptysis, bilateral pedal edema with high-grade fever and chills. Also notable is the pain in joints, which is dull but well localized. Patient has had similar history of fever and joint pain in preschool age, which was relieved by large doses of unknown medication. Provisional diagnosis of acute rheumatic fever is made.
I want you to stop here, Jaimin.
Yes.
You mentioned about that pain in joint.
Yes.
Like we discussed few differences between RA and this joint pain of rheumatic fever. Tell me which one of them is erosive, RA or rheumatic fever arthritis?
Rheumatoid arthritis is erosive.
Right.
Yes. Subchondral sclerosis and all happens. Yes.
Right. Now, as you told that if the positive organism for this arthritis is group A beta hemolytic streptococcus. So is there any other arthritis which is caused by this streptococcus group?
Other arthritis.
Have you heard about the term PSRA? Post-streptococcal reactive arthritis?
No, I have not heard about it.
Okay, it is also caused by streptococcus, but the difference is that it will involve small joints and it will be less responsive to NSAIDs. Okay?
Yes.
Right. Now you have, in the last line, you have written that the provisional diagnosis of acute rheumatic fever is made. Can you tell me how did you reach to that diagnosis?
With rough going through the history roughly, most of it matched with modified Jones criteria.
Okay.
Yes.
So, can you tell me how did you apply Jones criteria?
Because this is a moderate to high risk demographic.
Very good. First of all, you have to establish the population risk, right?
Yes.
Like whether the patient belongs to a low risk population or the high risk population, because the criteria are slightly different in both of them. So you establish the fact because the patient is of lower socioeconomic class in India. So mostly patient is having high population risk. Good. What was the next step that you did?
After later, when the lab tests were done, I also asked to measure the ESR and the CRP.
Okay. What is the step 2? Will you directly apply the Jones criteria or you have to establish something else before that? See, in the beginning of your presentation, you told me that there is the inciting event of throat pain.
Yes, sore throat is the inciting event.
You have to establish the evidence that patient had that throat infection. So, what are the ways in which you can establish that yes, patient had that throat infection. What are the diagnostic methods to confirm the throat infection?
Yes, we can do a rapid swab test. Then cultures are done, and sputum analysis could be done.
Anything, because culture reports take time, right?
Yes.
So anything which is like you send in morning and you get in evening, any other test that you are aware of?
PSR can be done, PCR, sorry.
Okay.
And a rapid swab test, I said, it is.
Have you heard about ASO?
Yes, ASO titers and anti-DNSB titers.
What is the unit of ASO titers, Jaimin?
I'm not aware of the units, sorry.
It is TOD unit, TODD, TOD. And what is the cutoff? Like when will you consider ASO positive and when will you consider it negative? In children,
I'm not aware.
Okay, in children, the cutoff for ASO titer is more than 333 TOD unit, and in adults, it's more than 250, right? So what if, like, you cannot directly apply the Jones criteria. First you did right, you established the population risk. Your second step is to establish the throat infection. Without that, you cannot proceed to Jones criteria. Okay, so let's assume that you did that ASO titer and comes positive. Now you will apply the Jones criteria. So tell me the Jones criteria.
Jones criteria, especially in moderate to high risk populations, is that there should be arthritis, polyarthritis, then subcutaneous nodules, erythema marginatum, and pseudoamphoria.
But you told that this patient is having in high risk, in the high risk population. So in high, you will consider monoarthritis as well or not? Or it has to be polyarthritis only?
No, monoarthritis should be considered with high risk populations.
In high risk population, even monoarthritis can be considered, right? Okay.
Yes.
So one you told me arthritis, second you told me carditis. And what are the rest of the three?
Subcutaneous nodules, erythema marginatum, and pseudoamphoria.
Right. And what are the minor criteria?
Minor criteria are fever greater than 38 degrees Celsius.
Right.
Then prolonged PR interval and ESR cutoff and CRP cutoff.
Right. And something else? One clinical is also there in minor. One clinical features. It is polyarthralgia and monoarthralgia.
Yes, arthralgia is minor.
Having arthritis. In the minor, we are having arthralgia. Okay. So when will you say that yes, the criteria is fulfilled? How many major and minor do you need?
2 major or 1 major plus 2 minor can be diagnostic.
Right. It is in the case of first episode. But your according to your history, it is recurrent, right? Because in patient also had a preschool history also, right? So in case of recurrent acute rheumatic fever, what is how the criteria changes?
For recurrent, we need 2 major plus 1 minor, or 2 minor, or even 3 minor can be used.
Right. Even 3 minor can be used, right?
Yes.
This is the change, right? Okay, now you move ahead, Jaimin.
Yes. I have begun with the general examination. I have examined my patient proper light and exposure. The patient is conscious, cooperative, and oriented to place, time, and person. Pallor on nail beds and tongue is present. There are, however, no signs of icterus or in sclera or skin. Sorry. There is no evidence of digital clubbing, cyanosis, lymphadenopathy. Noticeable edema is present on both lower limbs, more significant at feet. This is consistent with her complaint of swelling and redness.
Okay, Jaimin. Can you tell me some non-cardiovascular causes of pallor?
Anemia can be there.
Yes. So look, cardiovascular also you tell me. Both cardiovascular and non-cardiovascular causes of pallor. One is anemia, right?
Then if the patient is hypotensive, it can become pale,
yes,
especially
in case of shock, right?
Yes,
right,
shock, yes.
Also in case of hypothyroidism, patient may not be anemic, but pallor can be present.
Yes.
Okay. Now, can you tell me some cardiovascular causes of anemia?
Cardiovascular causes.
Why are we so concerned about anemia in CVS patients?
Because it can exacerbate the CVS dyspnea and the lightheadedness, and it
is itself a precipitating factor for failure, for heart failure,
yes.
right? It's very important to correct anemia. Okay. What are the cardiovascular causes of anemia? This is like for management purpose, but can CVS cause anemia?
Yes, if it is infection or neoplasia, anemia will be present. Anemia of chronic disease.
Only cardiovascular causes of anemia I want to know. See, in case there are mainly 3 causes of anemia in cardiovascular cases. Like if the patient is having prosthetic heart valves, then it can cause microangiopathic hemolytic.
Angiopathic hemolytic anemia. Right? Yes.
Then have you heard about HEAT syndrome? HEATS, HEYDE, HEAT syndrome.
Yes, it is because of aortic valve calcification.
It is seen in AS, right?
Yes.
That also there can be anemia. Why?
Because the von Willebrand fracture is disrupted with the stenotic valve, and there can be bleeding.
Very good.
Yes.
Because of colonic angiodysplasia.
Yes.
Right. So one is due to prosthetic valve. It can cause microangiopathic hemolytic anemia. Second, we discussed what? HEAT syndrome. Yeah. And third, you forgot infective endocarditis.
Endocarditis, yes.
It itself causes anemia, right? Next, then you have mentioned about clubbing. Okay. Name some cardiovascular causes of clubbing.
Reversal of shunts will cause clubbing, the Eisenmenger syndrome.
Right.
Especially in this age group, we need to be careful about it because of uncorrected shunts in the first decade.
Right. Correct.
Then polycythemia can cause clubbing.
Cardiovascular.
Oh, yes. Aortic valve diseases can cause clubbing because of hypoxia in fingers.
Not very common. See, this one person has answered correctly. Infective endocarditis. You're forgetting that, right? Infective endocarditis is a very important cause of clubbing.
Yes.
Also, LA myxoma.
Yes.
So, can you repeat the 3 cardiovascular causes of clubbing for me?
LA myxoma, then infective endocarditis, and Eisenmenger syndrome.
Right. Which 3 out of these 3, which one is painful?
Infective endocarditis, it is
and
painful.
Which one is reversible?
Eisenmenger syndrome is reversible.
Is it?
No, it will not be. Myxoma is reversible once the tumor is removed.
Again, it is IE, infective endocarditis. Once you successfully treat it, the clubbing will go, right?
Yes.
Next, you have mentioned about cyanosis. Tell me, what concentration of reduced hemoglobin do you need to produce cyanosis?
Greater than 5%?
No, it's greater
5 gram
than
4%.
4.
Okay.
Greater than 4 you need. And what is the cause of differential cyanosis, Jaimin?
Patent ductus arteriosus causes. Good. Yes.
Next, you have mentioned about lymphadenopathy. What is the most common site of regional lymphadenopathy in a patient?
Commonest site of axilla?
Most common. Like you're sitting in an OPD and your consultant wants you to look for lymphadenopathy quickly. So what is the first place that you will look for?
Is it the cervical region?
Yes, it's neck, right?
Yes.
And which areas lymphadenopathy up to 2 centimeters is considered normal in adults? In which area lymphadenopathy up to 2 centimeters is considered normal in adults?
I'm not aware about this.
Okay, it is inguinal lymphadenopathy up to 2 centimeters, right? Then you have mentioned about edema again. So what is the term that we use for generalized edema? We use one medical term for generalized edema. What it is? Like one guy has answered rightly, anasarca. Can you tell me? Can you tell me some causes of anasarca or the generalized edema?
First, could be the cardiac causes.
Right. Good.
Then renal causes can be there, nephritic syndromes.
Right.
And then hepatic causes can be there, cirrhosis. Yes.
Right. Then you can have albumin loss in urine, right?
Yes.
That case also. Okay, move ahead, Jaimin.
The vitals are taken. Temperature is 101.9 Fahrenheit, measured with my thermometer. Blood pressure is 124 by 82 mm of mercury in supine position. In right brachial artery, bilaterally symmetrical. Pulse is 78 beats per minute in right radial artery, regular with normal force, tension and volume and no radiofemoral delay. Respiration is bilateral and equal rise of chest with each breath. Thoracoabdominal respiration is there.
Okay. Jaimin, what are the prerequisites of measuring blood pressure? Like you are sitting in an OPD and a patient comes to you saying that, please measure my blood pressure. So what things that you will make sure before measuring his blood pressure?
That the person is not anxious, because it can lead to, then the patient should be in a sitting position, and
sitting position, okay. With particularly, if I cross
arms
my
should be relaxed.
If I cross my legs and sit, will you measure my blood pressure?
No.
Yes, you have to tell them to
relax their limbs.
Legs, right?
Yes.
Anything else? If I come and smoke 5 minutes back and I tell you to measure my blood pressure, will it give accurate reading?
No, it will give a false high.
Right. If I consume coffee 10 minutes back and come to measure my BP, will it give accurate reading?
No, again, false high.
Yes. Right. So you have to make sure that patient has not smoked or drank coffee just a few minutes back. He is in a relaxed position with relaxed all limbs, right? Then can you tell me what is oscillar sign? Oscillar sign, Jaimin?
I'm not aware about that.
Oscillar sign is basically a sign of pseudo hypertension. When you inflate the cuff for measurement of blood pressure, you are having palpable radial artery, but it is not having pulse. It is not pulsating. It is palpable but not pulsating, right? So it gives you a false impression of high blood pressure. But so oscillar sign is a sign of pseudo hypertension, right? Then you have mentioned about the pulse. Can you tell me which is the best artery for assessing the rate of a pulse?
Is it carotid?
For rate.
For rate, it radial is used.
Yes, for rate it is radial.
Radial.
Carotid is best for character.
Yes, character of pulse.
Right? Can you tell me some non-cardiovascular causes of sinus bradycardia?
Non-cardiovascular causes. Hypothyroidism could be one.
Very good. In obstructive jaundice or advanced liver disease also, there can be bradycardia, right?
Yes.
And now can you tell me some non-cardiovascular causes of sinus tachycardia?
Hyperthyroidism is one.
Right.
Then anemia.
Right.
Then beriberi.
Right.
Then fistulae diseases. It can cause hyperdynamic circulation and increased pulse.
And also pheochromocytoma.
Right? Yes.
Right.
Episodic palpitations. Yes.
Right. Can you name some drugs which causes tachycardia?
Atropine is there. Dopamine. Adrenaline.
That is their effect, right?
Yes. Okay.
Which drugs are having side effects as tachycardia?
Amphetamines can cause tachycardia.
Okay.
And so mostly sympathomimetics I am aware of.
Nifedipine, okay? Nifedipine, the main is reflex tachycardia.
Reflex, yes.
Because of this reason, we have to come up with new drugs like bendipine, clindipine, which do not have reflex tachycardia. Then tricyclic antidepressants have tachycardia.
Yes.
Then phylline causes tachycardia.
Tachycardia, yes.
Right? Okay. Like physiologically, bradycardia is seen in what group of people? Physiologically.
Athletes.
Yes. What's the reason behind it?
Because their vagal tone is high.
Right, because of high vagal tone. Can you tell me what is Paget sign?
Paget sign? No, I'm not aware of that.
Okay. Have you heard about relative bradycardia?
Yes.
What it is? See, Jaimin, with every 1 degree rise in temperature, there should be increase in heart rate by 10. If it does not happen, it is called relative bradycardia. Also known as Paget sign, right?
Paget sign.
Okay, you can move ahead, Jaimin.
Then moving on to inspection. The patient is in a supine position and examined from foot end. The size and shape of chest is normal. Trachea appears in midline. Precordium appears normal. Apex beats seen. Heave seen at left parasternal region. Epigastric pulsations visible. No dilated veins visible over the chest. No scars visible on chest. Jvp raised on inspection.
Okay, I wanted to stop here, Jaimin. Can you tell me what are the features of normal apical impulse?
Okay, it is tapping in nature, and the location is left fifth intercostal space,
Right.
1 centimeter left of midclavicular line.
Right.
And yeah, so it is tapping in nature.
Occupies less than 50% of systole, right?
Okay. Yes. Yes.
Right. And in which cases apex can be absent? Apical impulse can be absent.
If the apex is behind the rib,
Right.
it is absent. Then in pendulating breast in elderly women, it is absent.
Right.
And then if it is grossly morbid patient, it will be absent.
Right.
And if the pericardium is filled with fluid,
Yes,
or
pericardial effusion, left
yes.
side pleural effusion,
Yes.
then also apex can be absent, right?
Yes.
Can you tell me what is the difference between a heaving apex and a hyperdynamic apex?
Hyperdynamic apex is when there is the apex is diffuse and it covers the whole palm. Basically, it is seen in volume overload situations.
That's right. It is seen in volume overload.
Yes.
Right. And whole palm, or is it more specific? It occupies more than one intercostal space. Hyperdynamic apex, right?
Yes. Yes.
And what is heaving apex?
Heaving is because of pressure overload.
Right.
Yes.
So will it occupy more than one intercostal space, or it will be restricted to one intercostal space?
No, it will be restricted,
Right.
contrary to the hyperdynamic one.
So what will make, so one difference that we have is that heaving apex will be restricted to one intercostal space, but hyperdynamic apex will be crossing one intercostal space. Now what is the duration of both the apex?
Hyperdynamic apex will be longer because of the increased volume.
Will be longer, or heaving apex will be longer? Pressure overload is seen in heaving apex. So it will occupy more than 2/3 of systole, right?
Yes.
Hyperdynamic apex will be occupy more area, but its duration will be comparatively lesser.
Yes,
right?
half of systole, yes.
Yes, it will occupy less. Hyperdynamic apex will occupy less than 2/3 of systole, right? In which patient position will you inspect for apex impulse? Like you want to localize apical impulse. In what patient position will you localize it?
Left lateral decubitus, because the heart comes closer.
No, this is the most common mistake. For localizing and for inspection, you have to keep the patient in supine position only. When you have to assess the character, then you can move the patient to lateral decubitus position, right? Next, you have mentioned about heave. Can you tell me how do you examine for heave? By like which part of the hand?
The ulnar border we will use and place it next to sternum on the left side.
Is it the ulnar border or something else? Like this is my hand, right? So from which part of the hand will you assess for heave?
If I'm aware, we place the hand like this, and from this area we measure the.
Can you like turn your hand this way so that I can see like okay?
This way.
It will be by the heel of the hand. Remember TH. For pulsations, you have to use your fingertips. For thrill, you have to use the head of the metacarpal. For heave, you have to use the heel of your hand. Okay, so you will use heel of your hand, and the location you told was right. Now, next you have mentioned what is the importance of heave? What it indicates?
It indicates right ventricular problems, mostly hypertrophy.
Only due to right ventricle, or it can be due to some other pathology as well? Like for example, okay, tell me.
It can be because of volume overload on the left side.
See, heave is seen either due to right ventricular pathology or LA enlargement, right? Both possible. So tell me which valvular heart disease will have the most prominent heave?
Mitral stenosis because of LA enlargement.
It will be MR, right? Because MR will have both maximum, or LA enlargement also and LV enlargement also. Then
Yes,
if I
yes.
mention some epigastric pulsations, how do we look? How do we examine for epigastric pulsation, Jaimin?
The patient will be in the supine position and
Okay.
a Valsalva will be performed.
Where will you stand?
On the right side of the patient?
No, you will have to stand at the foot end. Patient is in supine, you will have to stand at the foot end and you have to bring your level of eye to the epigastric area so that you can appreciate the pulsation. Sometimes you cannot do that. So what you can do, you can keep a piece of paper or a pen in that epigastric area and can notice it's the movements of pen or paper, right? So this is my inspection. But if I have to confirm my inspective finding of epigastric pulsation, how will I confirm epigastric pulsation by palpation? Do you know the method?
No, I'm not aware of the method.
Okay, you will use your thumb. You will put it in the epigastric area and will push your thumb upwards and backwards, right? If you can feel the pulsations at the tip of your thumb, it is likely due to RVH. If you're feeling the pulsations at the border of the thumb, it is because of hepatic pulsations because of tricuspid regurgitation. If you're feeling pulsations in the pulp of your thumb, it is because of aortic aneurysm pulsations, right? Next, you have mentioned about Jvp.
Yes.
Tell me, how did you differentiate between Jvp and carotid pulsation, Jaimin?
Carotid pulsation is synchronous with the apex beat because
right.
And Jvp will be synchronous with the breathing.
Right.
Then also during auscultation, I confirmed that S1 was synchronous with the carotid pulsation.
Okay, right. Anything else? Which
then,
is more lateral, Jvp or carotid pulsation?
Jvp is lateral.
Is lateral. And which is seen better, Jvp or carotid pulsation?
In this case, Jvp was seen better.
In every case, Jvp is seen better, right? Yes. Carotid is felt better, Jvp is seen better. Okay? Yes. What is the normal Jvp?
Jvp, it will be raised by 5 centimeters at an angle of 30 degrees.
Normal. What is the normal range? No, that's not right. It is 8 to 10. Okay. Right? And what is the unit of Jvp? It is centimeter of water.
Centimeter of water. Yes.
Never ever say mm. Right?
No, it is centimeter.
Centimeter of water. Right? Now, why do we always select right IJV? Like, why cannot we use left IJV?
Because mostly Jvp is due to right heart problems.
Is that the reason?
No, because on right side, the Jvp, the jugular vein is linear and it ends in the superior vena cava.
Yes, right. First of all, it is straight. It has a straight course, right?
Yes.
And it opens directly, right? And what about the left side?
The left side will, external jugular, it will join and then in the...
First of all, it's not straight and it will open into brachiocephalic and innominate, right? So it is not directly, left is not directly draining, right? Right one is directly draining, right? Okay. Jvp. What is frog sign? Jaimin, what is frog sign? It is related to Jvp. Let me give you a clue.
Yeah, but
okay,
I don't remember. Yes.
It's okay. It is the prominent Jvp or the prominent veins that we see, especially in AVNRT. Okay? Right. So, with the help of Jvp and pulse, how will you differentiate between AF and premature ventricular contractions, Jaimin?
With using pulse and Jvp, you said, right?
Yes. What are the components of Jvp? What waves? Can you tell me?
A, C, and V are the waves, and X and Y descents are the...
Right. So in AF, what part of Jvp will be absent?
A wave will be absent. Yes.
So one difference is this: that A wave will be absent in AF and it will be present in premature. Then
Yes.
pulse apex deficit, what happens to pulse apex deficit in AF?
It increases because the atria is, I'm not aware of the value, but
it
because
increases more than 10, right? Pulse
Okay.
apex deficit is more than 10 in AF and it is less than 10 in premature ventricular contractions, right? And which worsens with exercise, AF or premature ventricular contractions?
AF.
Yes, AF will worsen with exercise and PVCs will actually improve with exercise,
Yes,
right?
yes.
Okay, okay, Jaimin, move ahead.
Then moving on to palpation, patient is in supine position. The patient is examined from the right side of the patient. Findings in inspection are confirmed. No tenderness elicited. Trachea is in midline. Apex beat is palpable over left fifth intercostal space, 1 centimeter lateral to mid-clavicular line. S1 heart sound palpable. S2 heart sound is palpable. Left parasternal heave present. No rubs or thrills palpated. Carotid pulsations are normal.
Okay, Jaimin. What are the factors that determine the intensity or the intensity of S1?
The rate of closure of mitral and tricuspid valve will differentiate.
So how does it affect that?
If
like
it is
tachycardia, so I will be having loud S1 or soft S1?
Soft S1 because the diastolic filling is decreased and the stroke volume will also be decreased. But if it is an exercise, then the S1 will be loud.
It will be loud, right?
Yes.
It will be loud. Okay. Any other factor, Jaimin? Only one factor?
No, if even due to degeneration and calcification, the intensity will differ. Such as
right, very good. In calcification, S1 will be
softer.
Very good, very good. Any other factor? Can you tell me why S1 is loud in MS?
Yes, because the atrial volume is increased, the atrial pressure is increased.
Yes,
so
because the pressure gradient, right?
Yes.
Because pressure gradient, the valves are very much far away from each other. So more far, or you can say the more the distance, more will be the loudness.
Yes.
Okay. Do you know how PR determine the intensity of S1, PR interval on ECG?
How it determines the intensity of S1, right?
Yes.
Because if PR interval is increased, the filling will be increased, and then the S1 will be louder.
It will be louder. Short PR. If patient
short PR is softer S1.
Short PR will cause what?
If
short
the PR
will cause what? It will cause loud S1. Okay. It will short PR, tachycardia, and it will cause what?
Loud S1.
Loud S1, right?
Yes.
Okay. So you have mentioned about this S1, right? Can you tell me some causes of reverse splitting of S1?
Reverse splitting of S1.
Yes.
Not aware of
anyone
S1.
from the comment section will like to answer it? Okay. It can be seen in Epstein's anomaly, right? In case of RBBB, in case of spacing, right? See, Epstein's anomaly is very special because you see number of sounds, maximum number of heart sounds are seen in Epstein's anomaly.
Epstein anomaly.
Right. Okay. Call address is to fine. Okay, Jaimin, move ahead.
Regarding percussion and auscultation, percussion showed normal heart borders. Auscultation over mitral area, S1 is soft. Pansystolic murmur heard over mitral area, left mitral area in left lateral position with diaphragm of stethoscope during expiration, radiating to axilla and infrascapular region. Faint bibasilar crackles present. No significant sounds heard over other areas. S3 and S4 are not auscultated.
Okay, so what valvular pathology are you suspecting by your auscultatory finding, Jaimin?
I am suspecting mitral regurgitation.
Regurgitation, okay.
Yes.
So, which is the most common valvular lesion in rheumatic fever?
Most common is mitral regurgitation.
Right. So, most common murmur is also pansystolic murmur, right?
Yes.
And the most common valvular lesion in RHD, in rheumatic heart disease?
Mitral stenosis.
Right, very good. So in acute rheumatic fever, the most common valvular lesion is MR, right? But in case of RST, the most common valvular lesion is MS. Can you tell me the named murmur of acute rheumatic fever? Most common, you told me, is the pansystolic murmur of MR. But there is one special named murmur also, which is which has been given to acute rheumatic fever. What is the name of that murmur?
Is it Siegel's murmur?
No, it is Carey-Coombs murmur.
Yes, Carey-Coombs murmur.
Carey-Coombs murmur, right? Yeah. So, what are the other causes of pansystolic murmur, Jaimin? Other causes?
So, first one has to be tricuspid regurgitation.
Right.
Then aortic stenosis. Then
pansystolic murmur, aortic stenosis?
No, it will be early systolic.
It will be ejection systolic. So in pansystolic murmur, you have one is MR. Next you have VSD, right?
VSD. Yes, ASD also has a pansystolic.
Now tell me, what is the difference between pansystolic murmur and a holosystolic murmur?
In holosystolic, the intensity is same throughout.
There is only one difference, right? In holosystolic murmur, S1 will be clear. In pansystolic murmur, S1 will be soft, right? So yours is a pansystolic murmur because your S1 is soft, right?
Soft, yes.
Okay, so you are suspecting the lesion of MR, right? Okay, now just you have any more slide to show?
No, this is the last one.
Okay,
I believe.
Okay.
Yes.
So just summarize your case and tell me the provisional diagnosis.
Yes.
All the positive findings, just summarize them.
Okay. A 17-year-old patient named XYZ has complained of dyspnea and breathlessness, and also had episodes of hemoptysis and joint pain. Positive findings were that first is the most prominent positive finding is the pansystolic murmur heard over mitral area. Then epigastric pulsations, apex beat, and Jvp were increased. Then the rash was present with edema on bilateral lower limb.
Right. So if you apply this our Jones criteria, is it getting fulfilled?
Yes, it is getting fulfilled.
Okay, so tell me stepwise, how is it getting fulfilled? First of all, our patient belongs to high
moderate or high risk. Yes.
We have just complaint of throat pain, but we have not established the evidence of throat infection. But let's assume that we sent ASO titers and it has come more than 250 TOTs. So okay, that also. So next we are coming to our Jones criteria. So in major, how many major criteria are fulfilled?
Because there is fever and arthralgia. Sorry.
Fever is a major or minor?
Oh, sorry. Fever is minor. Rash and polyarthralgia are fulfilled.
Not carditis. You're having changes in all.
Yes, carditis also.
You are getting 3 major only. So your criteria is getting fulfilled, right?
Yeah.
Okay. Now tell me, Jaimin, how will you manage this case? As a doctor, what advice or what treatment will you initiate?
So for treatment, we'll do benzathine penicillin G 1.2 million units.
Yes. Is it a primary prophylaxis or a secondary prophylaxis?
It is secondary in this case.
Yes. Why secondary?
Because it is to prevent further manifestations of rheumatic heart disease.
Yes, because carditis has happened. Okay, you just want to prevent the residual damage or the further damage, right? So it is secondary prophylaxis. So tell me, if a patient comes to you, because all these patients, she's a 17-year-old female patient, right? She's young female, so her weight can be less. If any young female comes to you and her weight is less than 27 kg, will you give the same dose or you will reduce the dose?
I will reduce the dose.
Okay, so what dose will you give?
I'm not aware of the exact dose for low weight.
You will simply half the dose. Okay, you will give
600,000. Yes.
Okay. So what if the patient is allergic to penicillin? What will be your next step?
We will desensitize and use penicillin.
You don't have any alternative to it?
We can use macrolides.
Yes, you can use erythromycin, right?
Yes.
What is
Yes.
the side effect or the most dreaded complication of penicillin?
Anaphylaxis can happen.
Yes, very good. Anaphylaxis.
Yeah.
Now tell me, Jaimin, you have a patient with you, like in which you're suspecting acute rheumatic fever. Her age is 17. So you have started penetrator prophylaxis, right? So the first thing patient will ask you, कि जिंदगी भर लेना पड़ेगा? Will I have to take it lifelong? What answer will you give her?
No, there are specific age limits and durations you have to take it for.
Like, what you
in
will
this
do?
case,
what advice will you give to her?
That she has to be consistent with the dose, otherwise RSD will happen.
But for how many years? They are ready to be consistent, but for how many years? How will you counsel them?
Here we have to do for 5 years.
5 years?
No, for 10 years in this case.
For 10 years? Why in this case? Because patient has carditis.
Carditis, yes. Carditis is present.
Yes, so you have to give till 10 years or till her 25 years of age, whichever is longer. In our case, the longer part is 10 years. So you will advise that you have to take this at least for 10 more years.
10 years.
But when will you change your decision? Like, when will you say that you have to take it lifelong?
When there is carditis and
right now she is having acute rheumatic fever episode. We cannot say that she will have residual heart disease or not. When you call her in your follow-up and you repeat the 2D echo and you find out that oh no, there is residual, then you will advise that you have to take it for lifelong or at least till 40 years of
40
age.
years of age, yes.
Right? So, okay, you initiated Penidura, you explained her that you have to take it till 10 years more. Anything else you would like to do for this patient? What follow-up advice will you give her? One you did Penidura. Next, you have to manage her arthritis. You will give
NSAIDs.
What if she's having MR, right? She can develop failure anytime. So how will we manage the heart failure of acute rheumatic fever?
We will give diuretics.
Yes, like you will give diuretics. But what if she has refractory heart failure? Then what treatment option do you have?
If it is refractory, then we can do surgery of that heart or...
No, in refractory heart failure, you can give a trial of steroids as well. Okay? Any other advice that you would like to give to her, Jaimin? You want to discharge this patient. You gave Penidura, right? You explained everything. You gave aspirin. Okay? Anything else? When will you call her for an echo?
Echo...
You will call her after 1 month.
Yes,
okay?
1 month.
Mostly the acute rheumatic fever episode resolves within 3 to 4 weeks. So at the end of 1 month, you will call her, you will do echo to see the residual damage and you will explain her accordingly. Will you tell her to repeat you were telling about ESR and CRP. So will you tell her to repeat those markers?
Yes.
Yes. Right? You have to, you will advise that you have to repeat the markers every 2 weeks till the markers normalize, right?
Yeah.
So this was your diagnosis and this is the way you will manage your case of rheumatic fever. Okay? It was a good case presentation, Jaimin.
Thank you.
Very good.